The topic for the next session is cholecystectomy in cirrhosis, portal hypertension. And to chair this session, I would like to invite our esteemed chairperson, Dr. S.K. Sarin sir from New Delhi. Professor Shiv Sarin sir is the senior professor and vice chancellor in the Institute of Liver and Hepatobiliary Sciences, ILBS, New Delhi. He is the director and WHO Collaborative Center on Chronic Liver Disease and Viral Hepatitis at ILBS and President National Academy of Medical Science. He is credited with several new treatment modalities for liver disease, especially variceal bleeding, liver regeneration, hepatitis B, and acute on chronic liver failures. He has more than 680 publications to his credit, edited more than 13 books on liver diseases, and contributed more than 90 chapters in various medical textbooks. We have other esteemed chairperson to chair this session with us is Dr. Peush Sahni sir from New Delhi, senior professor and head of the department of AIIMS New Delhi. Sir did his undergraduate from AIIMS in 1976. He has been at the same institute throughout his career. He is presently professor and head of the Department of GI Surgery and Liver Transplant Program at AIIMS. He has been the president of ISG and editor of the National Medical Journal of India. Welcome, sir. My podium is over to you, sir.
Before Dr. Sarin starts, sir, Dr. Sarin, sir, Dr. Peush just sent a message. There was some tragedy in the near family, so he is not able to join immediately. Maybe you can start and conduct the session. Thank you.
Yeah, thank you, Dr. Kapoor. It's a pleasure to join the surgical galaxy, and I heard partly the last debate. I have the pleasure of hearing Dr. Ravindra, cholecystectomy in cirrhosis. I refer a lot of patients to our surgeons because we see close to 4,000 new cirrhosis a year, and maybe 30% of them are decompensated. And the incidence of stones in cirrhosis is a little high than others. So we have a challenge every day. Patient has umbilical hernia, patient has ascites, he's decompensated and has cholecystitis. And the second series of patients are those who come with jaundice, have cirrhosis, and gallstones and bile duct stones. So there are two categories of cirrhotics. One, decompensated with acute cholecystitis, and second, those who nudge a stone into the bile duct. So we would like to hear from you, how do we handle these patients, and or actually how you are handling these patients, so we can update our knowledge. And I must compliment Dr. Kapoor, who has started in Mahatma Gandhi now this excellent Jaipur surgical festival, and it looks like it should be a monthly affair, hopefully in future. Over to Dr. Ravindra.
Well, thank you, Dr. Sarin. This is Ravindra here. This is
Ravindra, sorry to interrupt. You would prefer to make it a live presentation, or you want us to play your video? Choice is yours.
Go ahead and place the presentation. I was going to thank you, and Dr. Sarin, I'll hold it back. Yeah, go ahead.
Okay. Please play the video.
Good afternoon, everybody. This is Ravindra. I'm one of the abdominal transplant surgeons at Duke University in North Carolina in the United States. I deal mainly with the transplantation of the liver, kidney, pancreas, and intestines. My relationship with Dr. Kapoor goes back all the way to 1991 when I first met him. And I trained under him for 3 years, and he's an outstanding teacher and mentor. It is no exaggeration to say that I learned open gallbladder surgery from him and laparoscopic surgery subsequently. My first 3 open gallbladder surgeries were done under his guidance during the second week of my fellowship, my M.Ch training at Lucknow. At that time, gallbladder disease was very uncommonly diagnosed in southern India, And at Jaipur in Pondicherry, I had only seen 2 cholecystectomies in my 3.5-year stay there. My brief today is to discuss cholecystectomy in cirrhotic patients. I will start sharing my presentation here, and we'll be happy to answer any questions at the end. I hope you can see my slides here. I'll start here. Cholecystectomy and cirrhosis in cirrhotic patients can be a real challenge, not as much surgical as management of these patients in the postoperative phase. And there's a lot of derailments in physiology that occur, which come in the way of a successful recovery of these patients. Briefly, first, let me discuss the gallstones and cirrhosis. Patients with cirrhosis have increased risk of developing gallstones. This risk is as high as 5 times in some series. And the prevalence of stones increases with duration of disease. Gallstones have been noted in as high as 24% of patients when the explanted liver at liver transplantation was analyzed. And other significant point to note is that black pigment stones are more common in this population as compared to the general non-cirrhotic population where cholesterol stones predominate. Why are we so concerned and in dealing with cirrhotic patients, whether it's cholecystectomy or otherwise, and particularly with relevance to cholecystectomy here, anatomy is going to be different, more challenging because of venous collaterals from portal hypertension. These can be present in the hilum, in the callous triangle, and the gallbladder wall, in the liver bed itself, or adhesions from prior inflammation could be really vascularized. Stiff liver makes retraction of the liver and exposure of callous triangle to achieve critical view more challenging. Coagulopathy, presence of INR derailments, thrombocytopenia related to portal hypertension, splenomegaly are common. Peri and postoperative risks are significantly higher in these patients, with some of them ending up in liver failure. This postoperative liver decompensation is related to a diminished liver reserve in these patients. There are systemic derailments in physiology in these patients, hemodynamically, splanchnic vasodilatation, decreased vascular resistance. So these patients borderline hypotensive, they're actually hypotensive, lower blood pressures, increased cardiac output despite having increased cardiac output. And there's an inappropriate response to surgical stress in these patients. That's why postoperative phase can be challenging, kidneys may be impacted. Increased risk of bleeding, which we talked about. There's also an increased risk of infections. So all this culminates in worsening of SIDs, if present, or new onset SIDs after a surgical procedure, renal function derangements with acute kidney injury, coagulopathy in the postoperative period. All this can result in increased bleeding and requirement of blood products. Risk of postoperative mortality because of all this in cirrhosis can be as high as 25% in some series. So we need tools to help us risk stratify these patients, cirrhotic patients undergoing general surgical procedures like gallbladder. What are the tools do we have? These 4 listed here are important. A couple of them are well known to the audience here. Child score, MELD score. More recent ones are Mayo risk score, and vocal pen score is really hot off the press, published only in 2021. Let's discuss each of these. Child score is well known to the group here. I won't go into detail, but except to say that mild derangement is 5 to 6 points, 7 to 9 is moderate, severe decompensation is 10 to 15 points. MELD score initially described by Patrick KUMAR, published in Hepatology 20 years ago. Has withstood the test of time, and is the bedrock and the principle around which liver allocation is done worldwide for patients waiting for a liver transplant. So a score of over 13 to 15 is considered to pose a significant challenge to patients undergoing non-transplant procedure, that is general surgical, orthopedic, cardiac procedures. They have a high risk of decompensation. Mayo risk score, which is shown here, is a modification of the MELD score with addition of age, anesthesia risk category as ASA score, and etiology of cirrhosis, whether alcoholic, cholestatic, viral, or otherwise. These are incorporated, and this is being used in some centers for about the past decade, and it is better than MELD score, but still lacks as much granularity as we need for day-to-day practice. There is good promise now that we might have a tool which will make more granular data available to us when dealing with a specific patient situation. This is published in Hepatology in 2021. This is basically from University of Pennsylvania, veterans outcome and costs associated with liver disease. That's why it's called VOCAL. They analyzed data from 128 US centers performing where over 4,700 procedures were performed in over nearly 4,000 patients. A multivariable logistic regression model was used to define this 30, 90, and 180-day mortality using factors such as age, albumin, platelets, bilirubin, surgical category. This is unique, whether it's laparoscopic, open, orthopedic, vascular, cardiac, etc., emergency versus elective, and non-fatty liver disease presence, and obesity, BMI cutoff being 30. This model was found to be superior to the previous 3 models at all time points, and it is much more granular. I'll tell you what I mean. Here we are able to, for example, in this, we are able to add whether it's emergency or elective surgery, and the surgery type, whether it's open or laparoscopic, abdominal wall surgery, hernia, vascular, orthopedic, or chest and cardiac. Let's see from an example how this score, how these scoring systems match up. A patient with 60-year-old NASH cirrhosis, elective laparoscopic cholecystectomy planned for symptomatic stones. Bilirubin of 1.6, creatinine 1.4, INR, albumin, platelets, etc. as mentioned here. If we calculate the child score, it comes to 7, child's B, early child's B. Peri-op mortality predicted about 10 to 20%. MELD sodium score, based on the score of 20, which we get here, the mortality can be in the similar range. When we apply the MRS, Mayo risk score, this gives a 30-day mortality of 17, nearly 18%, and 27% in 90 days. When we use the vocal pen score, the most recent one, which we have more granularity here because we're able to add non-emergency surgery, abdominal lap surgery here, it actually decreases the risk. We find that 30-day mortality is only 5%, the 90-day at 8%. And this is much more granular. Because of granular, we're able to get a much lower predicted postoperative mortality here. Possibly we were denying surgery for patients in the past based on our earlier risk assessment. We can compare the risk scores here. The same patient here, Mayo risk score is 18 and 27%, here 5 and 8%. And in addition, we have the ability to discuss here risk stratify based on open versus lap. For example, here, open surgery, the risk is 90 days, nearly 29%. At lap, it's only 8%, less than a third, same at 30 days. So this granularity is only available with this score. Emergency versus elective, same thing here. 8% at 90 days versus 17% at 30 days if it's an emergency procedure. So we now have a tool that promises to be very useful for predicting risk and therefore deciding on the clinical approach. To operate or not to operate, this is always the question in cirrhotic patients. I'll summarize this in a couple of sentences. One is, we need to risk stratify, as we mentioned here. If they're symptomatic and if they're low risk, go ahead with surgery with good hepatology support. If they're high risk, avoid surgery unless it's life-threatening. They are better served by going the non-surgical pathway. Safety net of liver transplant. This is a concept I want to introduce here to folks who work in liver transplant centers. When score is in the 15 to 20 range, risk of liver decompensation is high. We would suggest that these patients undergo a complete thorough liver transplant candidacy evaluation. Once they are deemed to satisfy transplant criteria, then we can more confidently go ahead with the cholecystectomy. Should they decompensate, they can be salvaged with a safety net liver transplant. This is a consensus statement I'm showing you here from 1992, where the laparoscopic cholecystectomy was frowned upon for cirrhotic patients. This was the initial conference statement from 1992 consensus meeting. They said patients who are usually not candidates for laparoscopic cholecystectomy include, among other things, end-stage cirrhosis of liver with portal hypertension. We've come a long way since then. We now know that lap cholecystectomy can be performed safely in compensated cirrhotics. In fact, the outcomes may be actually superior in terms of decreased wound infection, liver decompensation, bleeding, and hospitalization. This is further proof here in meta-analysis where the clavity and Dindo grading of classification grade 1 and 2, 3, 4, 5 were significantly lower in the lap cholecystectomy group as compared to open cholecystectomy group. In patients with cirrhosis, the challenges at surgery include adhesions related to neovascularity, difficult retraction of the liver due to stiffness, difficult exposure of the callous triangle and difficult hilum exposure, as well as high-risk gallbladder from collaterals in the gallbladder bed. So what are the tips one might use to improve safety at cholecystectomy in these patients, laparoscopic cholecystectomy? One, umbilical port should be moved inferior. At or above the umbilicus risks injuring the umbilical vein, resulting in torrential bleeding or thrombosis later on. Use of additional ports. Retraction of the body and infundibulum rather than the fundus, because the liver may not move with just holding the fundus. Fundus first method, if callous triangle cannot be satisfactorily exposed. Avoiding blunt dissection is the key in these patients. All the adhesions should not be stripped bluntly because there's genuine risk of bleeding from collaterals. Energy devices are very useful. Bipolar diathermy, ligashore, harmonic, please use them liberally in separating adhesions. Argon beam coagulator is a godsend in dealing with this situation, as shown in this picture. Bleeding from the gallbladder bed is easily controlled. Topical agents, pressure, and most importantly, patience. Do not be in a rush to complete the procedure. If there's ongoing, get meticulous bleeding, apply pressure, apply topical agents. And if things are really bad, please resort to subtotal cholecystectomy. I'm not going to the details here. This is a picture here showing what appears to be gallbladder in the left upper picture. There's actually a dilated umbilical recanalized vein in the falciform ligament. It's just closer to the umbilicus. It appears like the picture on the right lower screen here, like a caterpillar worm. This close to the umbilical defect. The right upper quadrant is a picture of cirrhotic liver, and left lower picture shows adhesion of omentum with neovascularity, and the omentum gallbladder is not even seen. So the range of difficulty can vary in cholecystectomy. Left is an easy, straightforward gallbladder, even though it's cirrhotic, no big collaterals. Right side, you see a totally different picture. A lot of collaterals, firm gallbladder, stiff liver, vascularized omentum. Impact, and I would be amiss if I did not mention what is the impact of gallbladder surgery on subsequent liver transplant should the patient need it. Adhesions are significantly worse. Transfusion requirement goes up, even in more so in open as compared to laparoscopic. Portal vein thrombosis risk. If umbilical vein is injured, this can retrograde, spread into the portal vein, causing thrombosis, which can be a real challenge with liver transplant. In summary, cholelithiasis is more common in cirrhotic patients. Child's A and B or MELD less than 13 to 15, they tolerate cholecystectomy reasonably well. Child C, MELD greater than 20, avoid cholecystectomy unless it's life-threatening. Laparoscopic cholecystectomy is preferred to open. Most important message of this talk is actually this one. We need a good hepatology team supporting you before, during, and after the surgery for taking these critically ill patients through a difficult operation and a difficult physiology. Using the vocal pen risk stratification will help us provide more granularity in deciding who is a better candidate and a reasonable candidate for cholecystectomy. I'll stop here. Thank you very much. This is my email. Please feel free to contact me should you have any questions. Thank you.
Well, Dr. Ravindra, that was very nice. And with your expertise and stature there at Duke's. We learned a lot. I have few questions before I invite comments and questions. First is a comment. Gallstones, although are more common in cirrhotics, but the bile is half diluted. So the cholesterol is half, bile acids are half, phospholipids are half of normal. So they have a dilute bile. And this we published way back in early 80s, and there were a lot of papers by guys from near Washington. I'm forgetting Dr. Nair. So the first question, and I just wanted to touch base with you, and it will be worthwhile that we collect the bile of all cirrhotics with gallstones for surgery, and maybe we are doing right now proteomes and lipidomes just to see what the bile is like, and is it more lithogenic than others. That's a hepatologist's perspective. It's a dilute bile because it's a bad liver. But they do make more stones, there is no doubt. Maybe it is pericholecystic edema or varices, or it is the pigment which causes it. Now, coming to the surgical part, and I want to pick your mind on that. It's not the vocal pen is known, and we did discuss, I think this paper is by Nadeem and so, and we did discuss this paper in our journal club. The issue is not the surgery, issue is beyond surgery decompensation. So the interval between surgery to decompensation. Is your vocal pen model suggestive of decompensation? Because Mayo and others for mortality, we are not talking of mortality here, we are talking of decompensation post-surgery. So the first question is likely gap between surgery and decompensation, and has this been externally validated? And the second question is that if you, like you have also mentioned, if you have a difficult cholecystectomy because of collaterals, what would you be doing? Subtotal or leaving a tube, or how would you handle this difficult surgical patient?
Yeah, thank you, Dr. Sarin, for the question. So vocal pen, the initial publication was in January of 2020, this year. And subsequently, the authors have validated it by independent two other centers have published validating this using other data sources. So it's pretty early on. It's being applied only in the past few months, I would say, across mainly largely at the bigger transplant centers in the US. So it does give in the calculated, the app is easily available for calculation, and it does mention the risk of decompensation after surgery as well. And the duration, it is part of the calculation. It gives below the slides, I probably did not emphasize that. So the mortality is mentioned, but also the risk of decompensation. And the duration is variable. We've had, for example, when the MELD score has been in the high teens to early 20s, we've had patients who decompensated. As I mentioned, we go through the process of liver transplant evaluation and have them listed or approved by insurance firms before we embark on the cholecystectomy. And oftentimes we get away and it's not a problem. Occasionally it does help us out. And the decompensation may happen as early as in the first week. Sometimes these the ascites and other derangement that set in, they may not lead to a transplant requirement or liver requirement for maybe 2 or 3 months. They just linger along, managed with hoping that the score fluctuates a little bit, and something else like event they get an SPP or something, and then that precipitates a liver transplant. So there is a time frame. It need not be immediate. It can go on for a few months after this. And regarding the question of difficult gallbladder, so since we have the luxury of a fallback mechanism, if we can get these patients through the evaluation committee and have liver transplant as an option, We do, if we find it's difficult, mainly because of bleeding or other challenges, we do not hesitate to convert to an open procedure. So it is going to be, because we know that open may have a higher risk, but there is some data to say that lap to open conversions may not be as bad as trying open right from the get-go, because a lot of the dissection has been done. So for different reasons, we do not, if we think there's a challenge, we go ahead and convert to open. The patients who are high risk and are not approved by the transplant committee, they become a big challenge. So unless it's a life-threatening event, and even then we try percutaneous cholecystostomy, or with good endoscopy skills, they're able to get transpapillary drain to decompress the gallbladder. That has worked well in those situations.
Ravindra, there is a question from Dr. Rebala Pradeep. Is there any role of cholecystostomy and extraction of stones in a high-risk symptomatic patient?
So high-risk symptomatic patient, thank you, Pradeep, for the question. High-risk symptomatic patient, if they come in with cholecystitis, we would prefer to do a cholecystostomy. And once it's cooled down, they are much more amenable to a laparoscopic cholecystectomy, even in a cirrhotic, provided, of course, the score is not more than 20. And but we do not do the gallstone extraction in these patients. I would welcome any comments on that, but that's not something procedure we do.
I think Dr. Mathur wants to make a comment. Yes, sir.
Yeah, it's coming to what Ravindra said. Ravindra, excellent talk, well covered most of the things. Yes, regarding this extraction business, yeah, that's one of the thought process which can come in such patients. That if you have done the cholecystostomy through the tract, you remove everything and burn off the mucosa inside, either using the laser or the argon, and burn off this thing, and then it will not secrete much. The other thing is that internally you can block the cystic duct if you want. If you burn all the mucosa, then it will not secrete anything, and then see what it can happen. Okay. But extraction is a possibility with the burning of the mucosa.
Yeah.
Rather than cholecystectomy, particularly if it is a decompensated cirrhosis. No.
Thank you. One more point. I know we are running out of time, and for the excellent talk, Dr. Ravindra, one more point. You have a patient who is likely to go for transplant in next, maybe his MELD is 14 or so. He's likely to go for transplant maybe in a year, but he's not listed, but has recurrent cholecystitis. And he, like in India, doesn't have a donor now. So would you take up the risk of doing this surgery for gallbladder without a TIPS? Or would you like to do a decompression before you take up for gallbladder surgery?
Yeah, thank you, Dr. Sarin. So TIPS we've used as a means of reducing portal hypertension and possibly postoperative liver failure, not for cholecystectomy, but more often for more complex procedures like total colectomy, ulcerative colitis patient, or large ventral hernia repair, but not for cholecystectomy. Cholecystectomy, we preferred MELs as high as up to 20 to get them through a liver transplant eval if possible, if it's more than 15 and the hepatologist is concerned, before we embark. But less than that, most often we are able to get them through a cholecystectomy. And Dr. Sikora, Dr. Sikora has asked to put out a comment on the chat. Thank you, Dr. Sikora. Dr. Sikora, for all those who know, he was my teacher too at Sanjay Gandhi, and I learned a lot from him. His comment is about extrahepatic portal vein causes of portal hypertension. Generally, the portal hypertensive collaterals in the extrahepatic cases are much easier to deal with, and the coagulopathy, the derangements, risk of postoperative liver failure are much significantly less. So I think surgically they are more amenable to getting the gallbladder out successfully without the perioperative and postoperative risks.
You can very quickly comment on Dr. Sridharaya's point, and then maybe we can close this session.
Yeah, thank you, Dr. Iyer. It says comments on EUS guided drainage with lumen opposing stents in non-surgical candidates. So most of the time in these patients, we prefer to go down transpapillary stenting of through the cystic duct for decompression. We have not used EUS guided drainage. If you have experience, I would be glad to hear, but that's not a common practice in our center.
Bladder wants to say something.
Yeah, Dr. Ravindra, I think what you said about EHPV is completely, different from what we feel at this part of the, this thing. It's extremely difficult to do a cholecystectomy in case of EHPVO. In fact, cirrhotics, if it is a well compensated or child A cirrhotic, probably technically is not at all difficult. But EHPVO, you just, those look at those veins over in the hepatorenal ligament and over the gallbladder. They just scare you away to, like thing. So technically, it's very difficult. In fact, half of the cases probably you end up doing a subtotal cholecystectomy, or maybe just open and remove the stone and close it. Removing gallbladder is a nightmare in these patients. That is what our experience is. I'm sure Dr. Sadi could also agree with it.
Yeah.
Yeah,
I agree with you.
I think we will have
Very
to
valid point.
move
I
on.
was mainly comparing it with the outcomes with liver failure. So the poor management of those and the outcomes are.
No, I'm talking of
better than these.
intraoperative problem, intraoperative issues.
Yeah, intraoperative issues, you're probably right, but even those are,
Probably I am right. In fact, it is a nightmare operating on these patients. Yeah, we see more than.
I think we will move on. Yeah. Yes.
All right. Thank you, Ibrahim, for your comments.
Quick, very quick, please. Dr. Chaube.
Cholecystectomy in cirrhotics and patients with EHPVO in peripheral, because this conference is mainly for the general surgeons. When we started in earlier 90s in India, the 3 contraindications for lab chole were suspected carcinoma, the cirrhosis, and the bleeding diaphysis. I don't know why now it has become popular. And as Dr. Abdullah said, it is very difficult to do a cholecystectomy. Even in the best centers in India, I can say laparoscopically. Every patient, if you do a cholecystectomy in a case of decompressed system, he will lose at least 2 liters of blood if you do even a partial cholecystectomy. So I think it should be a contraindication for all general surgeons. So, surgery in cirrhotics and also in portal hypertension.
I think we can conclude by saying that all these cases should be done at centers which have expertise both for laparoscopic surgery and for liver support, because both these problems are there. I think with that we will have to close this session. Vinay?
Thank you, sir. Thank you, Ravindra sir, for such a nice talk on the topic, which is always a nightmare for the surgeons as well as for the GI surgeons. Thank you, sir, Sarin sir, for chairing the session.